I had never really thought about what would it have been like to turn 18, leave my home, and not have my parents to fall back on and save me every time I needed something, to pay the bills, or just to cry about something, a heartbreak that I just had, I think everyone's acknowledging now that foster care is not a great experience for kids. Even sometimes it's a necessary thing to do, but I think there's a real desire to try to think of what can we do to try to preserve this family? How can we keep the family together? I'd really like to see communities step up a little bit differently and for there to be some more education in the community so that teachers, neighbors, people at church, folks are really understand how to identify what's going on with the family and have them actually step up and try to help and support in those situations as opposed to picking up a phone and calling the hotline.
Idaho. What's the framework that you're going to apply to Idaho?
Yeah, so what we really look at is we look at
Cheryl, so excited to have you here. Thank you for making the time. Thank you for coming on the podcast. I don't know if you remember this, but the first time we met was at MHPA, I think over a year ago now. And I came into a panel that you were giving on child welfare, youth and foster care. And I was one of those annoying people who asked a question. And you ran up to me afterwards and was like, "Hey, we got to talk. I want to hear about what you're doing." So it's been so great to have so many conversations over the last probably year and a half. And I've come to really respect you, your team, the work that you're doing. And so I'm really excited to dive in and honestly just hear more about your philosophy, what you are seeing when it comes to the child welfare, the youth and foster care system. So I'd love to start, if you're open to it, by actually rolling it back to your early days as a counselor. And I think that right after you finished your master's degree, you went into counseling. Can you tell me about those days and sort of what it was like for you and maybe why you wanted to be a counselor and serve folks in that way?
Sure, yeah. Well, it goes back a little while for me, but yeah, I'd love to talk about that. It's interesting because I feel like the work found me as opposed to me actually finding this work. I was really just looking for a job. I finished my master's degree, and back then, it was interesting how you looked for a job. There weren't online resources and things like that, and my husband saw a posting at the university and said, "Oh, you need to go look at this job that's down there." So I go look at the posting. The posting he was talking about was gone, but there was a posting on for the Victim Assistance Center in Houston, and it was working with children who had experienced some form of trauma, women who were victims of domestic violence, sexual assault, family members who had experienced a murder in their family, things like that. As a new graduate, I was nervous about that, but at the same time, I needed a job, right? And so I did apply and was hired, and honestly, I fell in love with the work. It was an incredibly supportive environment. It was a lot, of course, going on, but really just getting to really understand what's going on in individuals' lives when these kinds of things happen. And it's really easy, I think, sometimes for us to sit back as professionals and be sort of judgmental about what's happening, even when families are experiencing different kinds of traumatic events or there's issues going on with the children or how the family's functioning, and to really be able to see how they're functioning day to day and what the barriers are to be able to help them. I mean, it's really just driven everything that I've done even since then. So after doing that, I went into community mental health, also working a lot with children and families, and then eventually into managed care. But really, I think it's that work early on that really has just inspired me to keep going in this profession and this specific line of work within the field.
So that was your first experience in professionalized healthcare, child and family support as well. What was it about that experience that clearly left such an imprint on you? I mean, you've dedicated your life to this. You're now the VP overseeing most of the business development in foster care, if not all of it, in child welfare at Centene. Like, you've committed your entire career to this. Like, what was it about that experience that really stuck with you?
To me, it was really being able to feel like I was making an impact really quickly. These were individuals, it was a grant-funded position. So these families and individuals that sought services with us really didn't have any other means to be able to access services to address their mental health needs at that point in time related to their trauma experiences, and realizing that there's a real opportunity there to make an impact in those lives and to be able to see that happen really just right before your eyes, to me is what really got me hooked essentially on the work and being able to just make that difference and make that impact and to see how you could really transform lives, honestly. And not obviously, it's not me specifically, but working with them and working together to be able to see them fulfill, their goals and reach the outcomes that they wanted to achieve.
I bet seeing the transformation in person when you're doing it, when you're supporting, there's probably few things that are as gratifying as that.
It's so rewarding. It's incredibly rewarding. And in that particular position, we did multiple things. Like I was the counselor there, but there were other things happening related to supervised family visits and really being able to be a part of some of those dynamics and the advocacy role for individuals who had been victimized by a crime and being able to see all those different aspects of things from the family dynamics to the court system to, all the different things that happen in an individual's life when something like this happens to them. It is a really rewarding experience to kind of walk beside them and see them actually start to achieve some success.
I imagine that was a its own master's degree in terms of the system of care.
It was so eye-opening. I said before, there were three things you're afraid of. You can go to school for in behavioral health. I was worried about testifying in court and having to call 911 if someone was threatening suicide, or call CPS whenever you see things happening in a family. In that job, I probably did all three of those within the first 6 months because you just experienced everything right then. And I think that's part of it too. It was just so constant that also sort of keeps you going because you're going from one thing to the next. But also, I just have to credit the environment that I was in with my colleagues. I mean, it was a small organization, but we were tight and we were really there for each other. And they were difficult cases, but we were talking to each other and supporting each other as we were managing those things, which was also, I think, really important and a big factor that kind of kept me going.
Yeah, I imagine that there was probably, and you can correct me if this wasn't the case, but I imagine there was some eye-opening moments about the fear of those three things, which is like, oh, actually, this is the role. Like the role is for children who are being abused. The role is for people who have very severe mental illness. Like this is the work. And yeah, I imagine that working alongside humans who also care as much about the people that you're serving, but also in as high stress an environment. In a way, it's sort of like a sports team, right? Like you're going to mesh with those people because it's so stressful. It's so high demand. Are there any stories or moments from that time that really stick out to you that you think about when you think about designing the system of care today? Like, are there sort of like core memories that you have?
Yeah, I think what really stuck with me especially as I've developed the programming, in the current role is really those family dynamics and really understanding. I don't know if I would say there's a specific thing, but understanding barriers that families had. So thinking about transportation to get to appointments or issues related to trying to really navigate. Am I going to put gas in my car to come to take my child to counseling, or am I going to buy groceries? And the idea that they had to make those kinds of decisions and kind of understanding that we really have to step back and not assume that we know what's going on and not think about kind of what's wrong with this dynamic, what's wrong with the situation, but instead really step back and ask questions about what's happening and what's happening in that family unit, what's happening with the child. And those are, I think, critical pieces that we have to think about when we're working with families, is that there are a lot of things that are going on there that you may not understand and that you've got to ask the right kinds of questions so that you can try to get to what the root cause is and see what you can do to address that.
Yeah, I mean, the realm of social needs is as broad as humans are, as broad as needs are. And I think something we're going to talk about in a little bit is designing an actual system of care to help address some of these needs. But I imagine that if you're acknowledging that even at the direct care moment, it can be challenging to uncover and assess the actual needs that people have, like stepping up levels into a system of care and designing that, I imagine that the separation can make it challenging to actually be able to address those needs.
Absolutely. And I think that that's really what's important is that you have to constantly make sure that you're staying connected with that, and because if you do, the farther you get away from it, the easier it is to forget about some of those things. But whenever when you're encountering it every day, then it stays just at the forefront of your mind in terms of what you've got to be considering as you think about your programming or you think about how you're working or, establishing your practice.
I want to talk about the current state of the child welfare system. But before we do, can you give me your own sort of historical context on what you have seen change and sort of, from the days of working as a counselor now all the way through to leading this operation at Centene? What have you seen change and what have you seen stay the same over your time?
Yeah, good question. So we've seen a lot of change, I think, recently. Honestly, within the last, say, 5 years, we've seen some significant change in terms of the number of kids who come into foster care. So it's been a good thing. We see decreases in the number of kids actually coming into the state's custody because there's just a much bigger focus on prevention. I think everyone's acknowledging now that foster care is not a great experience for kids. Even sometimes it's a necessary thing to do, but I think there's a real desire to try to think of what can we do to try to preserve this family? How can we keep the family together? And so we are starting to see those decreases in those numbers. And so we're seeing that consistently across the country where we're working. It's not something that's just a specific state. I think the things that I see staying the same are while there is that shift in thinking in terms of how do we support the family and bringing fewer kids into care, I think that we still need to do a little bit more. We bring kids into foster care almost always. The majority of the time, it's due to some form of neglect. I think a lot of times people, when they hear about foster care, they think it's kids that have been abused. And certainly that does happen. But I shouldn't say almost always, but definitely more than half of the time, you're looking at some form of neglect. So it could be that the parent is unable to care for the child because of their substance use disorder or a mental health condition, or it could be an inability to care for the child because of issues related to poverty. So there's a lot of socioeconomic factors that go into that. And so being able to identify how do we support families to get the resources and their needs met in a holistic way with them together in a family unit, as opposed to removing the child from the family and then trying to work on those issues, I think is a big change that's happened. But I think we still need to do more of that work to try to keep more families together.
So you've seen a shrinking of the number of kids in foster care because of the additional focus, resources, commitment at, I'm sure, the state level, but also I'm sure at the managed care and healthcare level. And also that it's likely that there are still kids who should be accessing the system who are currently not because of neglect.
There's probably some of that that's still happening too. Obviously, there's going to be those families that don't kind of rise to that level of getting the intervention that they need. We see, of course, a lot of relatives that are trying to care for kids whenever there's an issue going on in the home. But I guess what I'm saying that's staying the same is more about the fact that there are those needs that the families have that I think we could think about how we can resolve those without it becoming a child welfare case, so to speak, but how do we potentially as a community work together better to support families whenever we see that need on a day-to-day basis?
Got it. So it's thinking about the child welfare system, not just as the safety net or the safety trampoline. As one of my, I interviewed a senator from North Carolina named Senator Bergen. He called it the safety trampoline. I love that. But it's not looking at it as just the safety trampoline. It's looking at it as how do we keep people off the trampoline in the first place?
Exactly.
Yeah.
Exactly.
So I'm actually curious about that because I think when you're talking about prevention, you're talking about resources, you're talking about the safety net. How upstream, how deep do you believe that the system needs to go in order to actually prevent kids from ending up in foster care? And I assume that the hypothesis, and you can correct me if I'm wrong, but the hypothesis is if you go more upstream, you go deeper, you keep kids in families, you keep them in homes, it's better for the kids, it's better for the families, it's better for the community, and it's also probably cheaper on the system. Is that true? And if so, what is your belief on how deep we should be going to try to support families and kids?
Yeah, I guess I'd like to see it not be something that is done by the system. I'd really like to see communities step up a little bit differently and for there to be some more education in the community so that teachers, neighbors, people at church, folks are really understand how to identify what's going on with the family and have them actually step up and try to help and support in those situations as opposed to picking up a phone and calling the hotline to make a report to get child welfare system involvement. So I don't think that you can go too far upstream in terms of supporting kids and supporting families and just making sure that they have that their needs are met and that we're identifying those families that are either in trouble or really on the verge, honestly. And so I think if we can think about it more as this is kind of everybody's responsibility. It's not just the job of the child welfare system. It's really the responsibility for all of us living in a community.
It's super interesting. When we talk about the social safety net, it really has, it goes beyond healthcare, right? You even identified a few. You identified transportation, food, like things that maybe now we consider healthcare, but definitely 50, 60 years ago were not considered healthcare. So you in your position in a managed care organization do take on the burden for a lot of the whole health beyond just the healthcare of these families, not just children. How do you see the role of healthcare, health insurers, health providers in this system of supporting families and keeping youth in the community? And is there a delineation that you see, or is it more of what you just said, which is like we can't go far enough upstream? Like, so how do you see healthcare separate from social safety support?
Yeah, no, that's a really good question. I really think that we come alongside and join them in terms of the work that we do from a healthcare perspective and the safety net. So I think that there are definite roles and responsibilities for each of us. And it's important that we don't try to do each other's job because honestly, that just gets confusing for families. So it's really important when we are working together that we are really working together and it feels more like a partnership as opposed to one person trying to do it all. Just take, for example, the Child Welfare Agency. They're responsible for, the safety of the kids, finding a permanent placement plan for them, those kinds of things. But as the managed care organization, our specialization is healthcare. So, it's oftentimes where the caseworkers are out there trying to find appointments for kids or getting kids access to a specialist where if we're involved, they're able to actually pick up the phone and give us a call and we can take that off their plate and work together with them to be able to work alongside essentially. So when you think about traditional healthcare services, I think that there's that way for us to be able to work together. Now, at the same time, when you start looking at those things, which of course we've now started calling social determinants of health or health-related service needs, all those new terms that we're having that I think in the social work realm, we've always known that those things exist. We always know that those needs have been out there. I think it's really about trying to identify whoever identifies that need and getting them linked with whatever those resources might be. And again, it doesn't have to be one agency doing it all. It's really understanding what's available within the community and how we can get families connected and linked to those services that are out there.
I think that's an interesting point that it's obvious when you say it, which is like in healthcare, just healthcare, there's many, many times where you are being linked between services. However, when we're talking about child welfare, social safety net, like it is definitionally a network of services because you have whoever is managing the guardianship of the youth, you've got the family who is no longer the guardian, you've got the healthcare providers, you've got the school. Like it's a much wider web of connectivity, which I think makes it way harder to coordinate. Anytime you're coordinating two people, it's terribly challenging. But when you're coordinating multiple stakeholders with a child at the center who can't be the one directing it, I imagine that poses a lot of challenges. Going back to what you said, which is we've actually made progress over the last 2-3 decades in terms of prevention. What has worked? Like other than just focus and resources, which I'm sure is important, but it's not everything. We've seen lots of things where there's lots of focus, lots of money thrown at the problem, and it doesn't work. So like, what have actually been the strides that have improved the getting less kids into the foster care system?
Yeah, I think it's really about changing a little bit about how the child welfare system does their job sometimes, right? So I think that there's a big shift between how you're supposed to jump in and try to resolve the problem versus coming in and working alongside a family. So I think kind of changing the way that system is viewed, which is taking some time because families have to view it differently too. It's not just about the child welfare agency trying to act differently. It's also about the families receiving help and kind of perceiving them a little bit differently too, to have that willingness to accept the assistance and not being fearful that they're going to lose their children. So I think that that's a big piece. And I think that that's something that has been that the system is working very hard to try to change. And I also think from a...
Sorry.
No, go ahead.
Is that just a cultural change of
It's a
how
cultural...
in the system view the role of the system?
And it's even how they're trained to view their role. And that takes time.
Separate the kids is to keep them in the family.
Right, exactly. So thinking about how you support the family versus, not, or how you support them. I shouldn't say not supporting them, but the way that you support them, which is by trying to think about what the removal is the last resort and how you can potentially keep that family together or find relatives to care for a child and things like that. I think that those two things end up being big issues as well. I think there's also an effort, even within the communities, to try to think about how does the community support the family versus reporting the family. You hear a lot of talk about that in terms of, you have your mandated reporters, but could we change that to be mandated supporters instead, and how you really kind of work alongside a family. And then I think from a managed care perspective, thinking about what we are looking at in terms of the healthcare services that we can deliver that can be helpful is really important too. So thinking about those services that can be delivered in the home to really focus on the strengths of the family and being able to capitalize and build upon those strengths versus, again, like I said earlier, figuring out what's wrong and trying to throw different solutions at it. How about we also figure out what's working well and how do we build upon what's working well and then figure out where the gaps are and where we can try to do some work to fill those gaps. So it's a real combined effort between how the system works itself, but then also how we design the healthcare system to be able to work alongside the child welfare system to meet those needs.
Yeah, and talk about designing the service delivery and array is a hard problem. Changing cultural ideas about what a system should be might be an even harder problem. So it's actually cool that that has come first, and I suspect that has been the work of thousands and thousands of people over the last probably 100 years to try to push us in that direction. And I think your point about mandated reporters, I'll share an anecdote from the work that we do. We often have to call Child Protective Services because we hear something from one of our teenagers that requires us to report. And without fail, probably close to 100% of the time, as soon as we inform the teen that a report is going to have to be made based on what they just said, and we really do our best to inform them about, hey, here are the things that you would say that we would need to do this for. As soon as we tell them that, they leave. And so it's like, I'm not at all saying mandated reporting is a bad practice, but the reality is when a child or their family feels like they're being threatened by the system, they're no longer going to participate in it, which means we're not actually going to be able to do anything. And I find that a very tough challenge. So can you actually tell me, like, what this reframe to mandated supporters, like, what does that mean? What if that were to happen, what would the world look like differently?
So what I would say, first of all, is we are not there yet, obviously, because you're in that mandated reporter category and you are in that situation and needing to make that decision. What we're really thinking about, and as I'm in conversations with people, it's kind of thinking about like the school system, for example, or your neighbor, more so than the professional necessarily. So when do teachers need to make that report? Do they need to report a family when the child isn't showing up with school supplies and doesn't have a lunch? Do they need, what is it that really necessitates them to make a report to the child welfare system versus when should they really just try to identify resources that might be able to support the family? If you're in your community and in your neighborhood, obviously we all, are supposed to report anything that we see. That if you do any training, you hear that, you learn about that. But is there an opportunity for you to see that your neighbor is struggling? And instead of making a report, should you see what you can do to maybe help that family? Is there something you can do to help care for the children, give mom a break? Are there some things that you can do to help connect the family with resources and support. So it's really about changing how the community is viewing the families, and those, especially those schools and churches and agencies where families tend to congregate and where you tend to see children, and helping educate those individuals about how they might be able to support a family and prevent involvement in the child welfare system. But there's risk associated with that. And that's what really, is really, I think everyone's trying to figure out, how do we potentially have individuals work in these more supportive roles without feeling like, well, gosh, if I do this and then something bad happens, then that's on me. And I should have made a report, and I should have gone that extra step. I shouldn't have taken that chance. And so trying to figure out how to navigate that is really tricky. But I want to go back to what you were saying too about just that, what that does to the therapeutic relationship, or just the relationship in general when you're in that situation of breaking trust, because I think that that is a big issue, and it does then impact that person's willingness to really trust another professional or engage in services in the future. I think it kind of impacts all of those things down the line. So I think that there is that need to kind of think about that and think about how that gets treated and handled. And I can go back to my days in direct care, and I had families that I reported, and I told them that I was going to do that, and they stayed with me, and we continued to work together and do family counseling. I had others though that were like, I know we have to get services, but we're going to get those elsewhere. And it really depended on the family. And sometimes I think it depended on what my relationship was like with them before making that report. So if we had been working together, that rapport had been established, and it was a real strong bond, then that was a little bit easier. It made it easier to overcome that and help understand what was going on. But if it was a newer person to treatment, then definitely, that it definitely became an issue, and they really, that trust was just broken, and it's really hard to gain it back.
Yeah, trust is so important. I mean, especially with the communities that we're talking about here, which for many parts of the last 150 years have not been treated well by many parts of the medical establishment, and then have rightfully so culturally induced challenges to why one might engage with health service providers. And so anytime that you're introducing more opportunities to create less trust, that does just, like, it hurts me a little bit. But again, nothing wrong with the mandated reporter thing, but these are all real challenges that come up.
Yeah, no, I think it's a good discussion to have. And when do you make that decision, and where do you draw the line? And I think it's worth revisiting and having that conversation and figuring out what to do going forward.
Yeah, and just if we could figure out a way to mobilize and incentivize a community to actually support, like, that feels like we should have another 2-hour-long conversation about that. But that's a really fascinating challenge, and part cultural, part service, part product. Like, I think there's a lot of interesting things there. I think let's save that for another conversation. Let's talk about designing a service array, which is essentially the work and the commitment that you've been doing now at Centene. We talked a little bit about some of the challenges still, which really the main focus here is going upstream into the community, preventing kids from ending up in the first place, and supporting the communities and the families. When you think about this problem that you've been solving now for quite a while, how do you even look at it? Like, do you see in your head the web of interconnected providers? How do you conceptualize what it even is that you're trying to design?
Yeah, it's a really great question. So I have to kind of go back in time a little bit. So we've been operating in the foster care space since 2008. So that's when we went live with our first contract to serve children in foster care through managed care. And I came on board in 2010. So I've heard the stories from 2008 and certainly saw where we were in 2010. And honestly, we were, the expression, building the plane while you're flying it. I mean, that's sort of what it felt like a little bit, because no one really knew how to bring the managed care world into the foster care space. These were two very separate systems that really hadn't worked together in the past. And so trying to figure out how to navigate that was tricky. Also looking at the fact that our contract was with the Medicaid agency, and then the child welfare agency serves as the parent of the child. And then here we are as the managed care organization. the Medicaid agency and the child welfare agency in most states don't really communicate with each other. So there's not really much of a relationship there typically.
Was Texas the first state that Centene went live with
Texas
this
was
in?
the first state.
Okay.
Yeah, they were the first state to create a specialty plan for children in foster care. Yeah, and we were awarded that contract and have had that ever since. So, but kind of figuring out how to make those agencies really work together with those agencies to be able to start communicating and start looking at how to solve some of the problems that we were seeing together was a big step and was definitely a very big difference for the state and for those entities. And then if you put on top of that all the providers out in the community too, and how do you try to figure out how to get everyone really working on the same page for the kids. And it's a complicated system. I think people don't realize how complicated it is. It's not as if kids come into foster care and then go to a foster home and stay there until they go back home. There's often lots of movement that happens, and they might move from one foster home to another, and it's not always bad. So I don't want to make it seem that all moves are bad. Sometimes it is related to a behavior or a medical condition, but oftentimes you're trying to get kids back with their siblings, or you're trying to get them closer to biological relatives and things like that. And so how do you navigate that and not lose sight of the services the child was getting? How do you make sure that they're not getting duplicate services? How do you make sure that you're not trying a therapy that failed before because you just didn't know it and now that you're with a new provider? So really kind of stepping back and trying to look at those broad systems issues and then thinking about how do you do the right type of care coordination and how do you put systems in place so that as much as possible, people have easy ways to communicate with each other. And it's certainly not perfect now. It's better than it was before. But really conceptualizing it is really looking at all those different systems and talking to everybody. It's not just about talking to the people that are with the state Medicaid agency or with the child welfare agency. Let's talk to those people who are utilizing the service, talking to foster parents and caregivers and finding out what's working and what isn't working. And so it's this constant changing and shifting in terms of exactly how we do this work so that we're really taking advantage of whatever might come along from a technological perspective, but also really meeting the changing needs of the children and the families that are in the space. So it takes that constant kind of communication and feedback loop so that we can try to keep up with that. And also acknowledging that even though we started this program in Texas, we are now in 21 states with 6 of these specialty plan contracts. But it looks a little bit different everywhere. So even though we have a framework that we take from state to state, it really looks different everywhere because the child welfare agency setup is different. The Medicaid service array is different. The needs of the community end up really being different from state to state. So we've got to be flexible on the work that we do.
Yeah. As you're talking, it makes me feel like, so my background before I got into healthcare was really in designing products. And one of the core ideas when you're conceptualizing what you should be designing is to really walk through the user journey from start to finish. And as you're talking, it sounds like you have a conceptualization of this, right? You're talking about the teen who enters, how they move around. How much does the teen journey guide how you think about where to slot in new things, where to make sure there's connectivity? Like, how much do you think about the teen journey?
Almost entirely the youth's journey. So thinking about what happens to them when they come into care. And again, looks different in every state. What are they required to do? A child comes into the state's custody. What appointments do they have to have? What providers do they need to see? What happens, essentially? And so we want to make sure that we set up something that's as easy as possible in that situation and really helps not only the family, but also the providers be able to make that happen within the timeframes that it's supposed to happen in. And then thinking through what happens throughout every step of that journey, whether those are things that the child welfare agency has put in place that need to happen, or whether it's really thinking about if this happens and if the child has this condition, if there's this diagnosis, if there's this need for services, then making sure that we have solutions for that, whether that is, escalating and needing a higher level of care, a more intensive type of intervention, really making sure that we can really provide some sort of solution across that spectrum, essentially, in terms of what the child's needs would be. But yeah, that's exactly what we really look at whenever we think about, how a state child welfare system works. What we're really talking about is what is that child's journey through the system and how is that set up and what does that look like?
What was the biggest eye-opening moment you had where you thought you knew what a youth's experience was, and then you talked to someone, you saw something, and you went, "Wow, I've been wrong."
The biggest eye-opening thing for me was when I found out really what it looks like when youth turn 18 and they're in foster care. That was the biggest thing that I think was a shocker to me, because I really felt like, I guess I hadn't thought of it, honestly. Kids turn 18 and they age out of foster care, so sometimes they stay till 21, sometimes they exit the system. And I had never really thought about what would it have been like to turn 18, leave my home, and not have my parents to fall back on and save me every time I needed something, to pay the bills, or just to cry about a heartbreak that I just had. And so kind of seeing what that was like for those young people and putting myself in that place, that was really the most eye-opening thing, is thinking about how these kids, these young people really exit the system with minimal support. And it's not that there's not an effort to put supports in place. So I want to be really clear. The child welfare agencies really do work hard to try to engage those young people earlier than that, to try to provide the services that they need, tell them about the way that they can be connected to different kind of supports. But nothing replaces your family. There's just not a replacement for that. And so thinking about that and trying to design systems that will help that population has been, honestly, probably the programming that I've spent more time changing since I've been at Centene, trying to find something that will work, because the outcomes are as bad as they are. And if, again, just put yourself in that position and just think about what that would feel like, and just understanding what there's just such a need to be able to do something to help young people who want nothing to do with the system at all anymore. They really want to turn their back on the system. And, oftentimes as the managed care partner, we really kind of start to be viewed as part of the system, which we like most times, right? Like this is really part of the system of care, and we are a partner here, and we're here to try to meet the needs of the families. But when the child is exiting foster care, when the young person is an adult now, we really try to get them to think of us differently. We're your health care. Everybody needs, health insurance. And so what if something happens? We're here to help with that. And then we can also, for helping them in those ways, in terms of just medical appointments and things like that, then we have the opportunity to find out, do you have housing? Do you have food? Are you able to pay your bills? Or what are you planning to do? Are you looking at college or trade school or job? And how can we potentially get you connected that way too? But it's, again, we're viewed as part of the system too, so that engagement piece is tough.
Yeah. I mean, it's hard for me to imagine an 18-year-old who's if they've had an amazing experience where they've been very cared for, I can imagine that they would want to continue that. But I imagine that's not the experience that most kids have. And I can't imagine an 18-year-old who has not had a great experience being excited about staying connected to their PCP after they leave. Like,
it's just not what they're thinking about.
Yeah,
and think about when you were 18, how often did you go to the doctor?
I don't know. And
Right.
it was never on my own volition.
Right.
It was,
Right.
I was fortunate to have a family who was like, hey, you got a
It's
doctor's
time.
appointment.
Yeah, you've got a dentist appointment.
Yeah.
It's time for that checkup. Those kinds of things, you're getting prompted to do that. But
I don't feel like I started doing that till I was like 25, 26.
yeah, because if you're not prompted to do that, you're like, I feel fine. I don't need to go. And so that need for health care, which is sort of our carrot a little bit, right? It isn't really something that is really that appealing, because I don't need that. And even if they have a chronic condition, they may not really be acknowledging that they have it.
Yeah.
And so they don't necessarily
Or substance use
even
disorder.
Right, exactly.
That's appropriately called out as a very challenging moment, because just any young person who has to go out into the world and fend for themselves, it's a terribly challenging thing to do. I've heard many, many stories of kids who, as soon as they leave, it's like they're out, they're gone off into the world. The likelihood that they might end up homeless or with a substance use disorder is like so high, and it's a very challenging problem, because you need people to buy in. You need those young people to want to engage in the supports and services, and it's a very hard problem.
It's tough. And a lot of times they want to go back to their family of origin, which is understandable too. They may not feel like they should have been removed in the first place and they want to go back to a parent. And sometimes those individuals are not in a place to be able to care for them and provide that kind of support. And so then that's another trauma that they experience with at that point in time in their life too.
Yeah. You mentioned you now support youth foster care and child welfare in 21 states. And you mentioned a framework. You said we have a framework, but it's different in every place. Can you give me the masterclass on the framework? Like, what is, if you were going to launch, I don't know if you're here now, but let's say, I always pick on Idaho. I don't know why. Like, Idaho. What's the framework that you're going to apply to Idaho?
Yeah. So what we really look at is we look at our care management model. We look at our provider network. We look at the partners that we need to have in that system. And we look at the types of training that need to be delivered, whether that would be with our provider community or with our caregiver community. And so we take those four main concepts and we start looking at what does that look like in this state? And we really start talking to people. If it were Idaho, we would get on the ground and start talking to advocacy groups. We would talk to providers. We would talk to foster parents and really try to figure out what the needs are and how are kids accessing services today? What's working well? Because that's the other thing I always ask, what's working well? Because we don't want to break whatever's working. So let's be real careful about that. But then what are the gaps and what are the ideas for solutions for what might be able to fill those gaps? And so really it's a puzzle essentially that you start to put together so that you make sure that you're meeting the needs of that state. So, with the Medicaid service surveys looking so different from state to state, that definitely has an impact. But even the provider landscape looks different in terms of what the provider shortages are, where they have plenty of providers and where they don't have as many, and thinking about what you need to do there to leverage the resources that are available in that state.
Is a new state rollout launch research process, is that where you find the most ideas about what's missing and what is new?
It is, because that's really where people are so eager to talk to you and really share that with you. So whenever there's a new state that's looking at moving, whether it's an existing Medicaid managed care state and they're just looking at developing a specialty plan for this population, or maybe it's a state that's moving to Medicaid managed care and this population is part of it and there will be a specialty plan. People, you have your subset of people who think, oh gosh, I really wish this wouldn't happen. I really want things to stay the same. I don't want the change. But then you've got those people that maybe they're not super on board, but they want to be a part of the change. If it's happening, let me try to shape it. And they're very forthcoming with what they see as the challenges are, and they see that as a real opportunity to bring something new and different. And so that's where we're able to be a little bit more creative, because we're sort of working with the state to shape what it's going to look like, versus states that are already kind of entrenched in some of the ways of doing things, where you're really trying to come alongside that. And I find that change sometimes is a little bit slower in those situations, because there is, while change can be really good, there's also that fear that change is going to, really cause some damage as well. So you've got to kind of weigh that out.
When you're talking at the state level, you're talking at the provider level, like I feel like an important moment in all that is making meaning and synthesizing what you're hearing, because everyone will tell you what they hate about the thing that you're trying to do and what's bad and you should fix, but you have limited resources. And sometimes what I've learned in doing a lot of design research is people will tell you what they think they understand about the problem, but they might not understand the deeper reasoning behind why that thing exists. How do you synthesize? How do you pull meaning from all of the different stakeholders when you're trying to develop a system of care?
Yeah, it's a really good question, and it's hard because you're exactly right. You hear about something, and so I can't tell you how many times you start running down a path of thinking, okay, this is what's going on, this is the problem, this is the solution, and then you talk to somebody and you're sharing that idea, and they say, oh, wait a second. Let me tell you why that is that way, and let me tell you what happened 5 years ago, and so now there's this in place, and we can't do that, and this is the reason why. But when that happens, then we are like, okay, get it. So what else can we do? Because this is still a problem. We got to acknowledge that this is still a problem, but maybe the solution that we were thinking we were going to implement isn't going to work, and so we've got to come up with something different. But it really is this constant, communication and really identifying who are those partners that you can make in the state that you can just keep going back to, because you've got to keep circling back. And as you're learning more, you kind of have to be able to test out your theory. Like, I think this is what I'm hearing. I think this is what's going on. Is this something that you think, tell me more about this. Now, I heard you say this one thing whenever I was meeting with you, and then I went over here and I heard something else. Tell me more about this now. So it is just a lot of communication, a lot of conversation, and a lot of documentation of everything that we're doing, because, you've got to really keep track of the work that you're doing so that you can kind of sit down and then pull it all together and spend some time really allowing yourself some time to do that before you, take a breath and then go back out again and start learning more and really kind of developing some solutions. But it takes some time to pull all that together and really make sure that you don't jump to conclusions and think you really understand things too fast. You've really got to check things out with all the parties that are involved to have a clear understanding about the problem and the solutions.
What is the thing that you're most proud of yourself for being able to synthesize and come to a solution that was not necessarily the obvious solution, but was like the right solution based on what you're hearing? Like, what are you most proud of?
Let me think. One of the big things that we've been working on, and I can't take credit for it, it's something that is done as a team, but we have developed a new model of how kids can access care through what we call foster care centers of excellence. And so these are primary care clinics that really have take a special approach in serving our children in foster care. And this was really, the concept started with our medical director in Texas, who said, if you have a condition, a complex condition, do you want to go to somebody who does this work a couple of times a year, or do you want to go to somebody who sees individuals like this every day? Obviously, you want to go to someone who sees them every day, right? And so if you think about children in foster care in this,
can you imagine going to your dentist and being like, how many patients have you seen? They're like, I don't know, like 3 this year.
Yeah, exactly. Or they're going to do a root canal. It's like, yeah, I've done a couple of those. You don't really want that. You want
No,
to,
thank you.
yeah. And so we started thinking about, okay, how can we specially design clinics that are going to really know how to handle the needs of families that are going through the foster care system, understanding what the child's going through, understanding what the caregivers are going through. And so we started this model in Texas, have expanded to Washington, Missouri, Oklahoma. We're expanding it in a couple of other states too. So we're definitely on a real mission to expand this work, because what we've seen is that kids who are served in these clinics actually are more engaged in their treatment. So they are getting their well child visits on time. They're getting their immunizations on time. And these clinics also really focus on being able to meet the full spectrum of needs of the family. So whether it's happening under one roof or through provider partnerships, they're meeting not only physical health, but behavioral health needs, social resource needs as well.
These are physical
These
centers.
are physical clinics. It's a primary care doctor, and we will designate them as a center of excellence if they meet certain criteria and have that desire to work with us. And then they're actually working really closely with our care management team as well, so that and we're providing ongoing training for them and their staff, ensuring that everyone from the front office staff to the providers have trauma-informed care training and really understand the needs of the family. And what I want to point out too is the stories that I really love about these clinics. It's not just about the fact that we're seeing better healthcare outcomes in terms of the metrics that we're measured on as a health plan, but also what the individuals are experiencing and the caregivers are experiencing. So if you think about a foster parent, they may have multiple children that are in their home. It's difficult to get to appointments, and it's certainly difficult to manage that for 5 kids. But if you're going to a clinic that really understands that, they're going to work with you on your scheduling. They're going to make sure that you get those appointments at the same time. I've had grandparents talk about the fact that, she's got to take a bus to get the grandkids to the appointment. She can't make it on time. A traditional provider might reschedule you for the next week. They might fire you as a patient. But at these clinics, they understand. We're going to thank you for making it. Come on in and we're going to see you. And so it's that kind of experience. So it's not just the outcomes. It's also just the experience that people are telling us that they have at these clinics that to me makes it so worthwhile. So it's one of those things where you go after it thinking, okay, get this specialization, you're going to see the healthcare outcomes that you want. But it's not just about the healthcare outcomes. We're seeing all these other positive impacts as well.
It's back to that trust piece. Like it's an opportunity to provide more trust to the kids and the families. I am curious. Like I should know the number. I apologize, I don't know, but I imagine there's somewhere between around like 100,000 youth in foster care in Texas. How many in Texas are there?
Oh, in Texas, about there's 20 to 22,000.
Okay,
That number has gone down pretty
yeah, so that's a
significantly.
lot less than I thought. So
Yeah.
how do you build a system of physical infrastructure that is geographically dense enough to be able to actually provide services across? Because Texas is a huge state, right? I imagine in Houston or Austin or Dallas, it's not hard. But if we're talking even some place like San Antonio, which is really sprawling, like how do you think about the geographic density and being able to provide a service like that? And maybe by extension, like if you were going to give advice to a state like Texas with both lots of metro areas, but then lots of rural areas as well, how would you advise them if they wanted to learn about or think about how to do this center of excellence model?
Yeah. So, we work it. I'm stumbling all over myself here, but basically, you can start one at a time. Actually, you identify one geographic area where you're going to start, and then you start just building over time and really working to spread across the entire state. So, if you're thinking that you're going to allow in a moment every child in foster care to have access to a center of excellence, you're just not going to be able to do that. It takes time to be able to do that. So, we're in. I'm going to misspeak here if I try, but I don't know if we're in every single child welfare region in Texas with a center of excellence, but we do have 12 in the state. Washington has 8. They've been working on this model for much longer. Washington does have a center of excellence in every child welfare region, but you're still going to have people where that's a drive. And so what we've really kind of promoted in those situations is maybe if we can get kids there for their first appointment, when they come into care and they've got to get their initial health examination, and they need to be evaluated to see where does the treatment need to go from here. Sometimes that's a really good place to start. And then maybe they go to a clinic that's closer to home for ongoing treatment after somebody who has more of the expertise is able to really evaluate the situation. But even so, we still have to take into account choice that people have. We don't force anyone to go to a center of excellence, even though we think it's the best place to go. We don't force anyone to do that, but we try to work hard to make sure that it's available and accessible. But it really is just one clinic at a time, one geographic area at a time, because it honestly ends up being your larger metropolitan areas that are more willing to do that to start with, because sometimes we've really found that these pockets of expertise already exist. There are people who are already really building their practice around this work or really have a strong passion for serving the population. And with just a little bit of extra help and some extra training, we can get them up to that point of where we would feel comfortable with them as a center of excellence. And so really identifying those partners that are really ready to engage with you on that makes it a little bit easier. And so identifying where kids are getting care now, I think is another really great place to start, so that you can think about, like I said, where the kids are getting services now and making sure that you equip those clinics with the services and the training that they need, so that you're not trying to disrupt the overall pattern of care. You're able to just build upon the infrastructure that's there.
I think there's 2 insights in there that are interesting. The first is like, don't boil the ocean. Start small. Start in. You obviously want to have a vision for how this thing could scale to support everyone, but your idea can start in one center or one location. You can pilot it, you can try it out. If it doesn't work or you need to make changes, much easier to do that at a scale of 1 or 2 locations than statewide. The other thing that I think you said that was really interesting is, like, oftentimes the answers to a lot of these large scale problems are already happening at small scale in the community with providers who are already doing it. And sometimes the right solutions seem to be just amplifying and expediting the ability for those people to do the work at a larger scale, or finding more resources to get them so that they can expand their reach. Because I'm sure when you went out and did this research, there are probably so many primary care clinics who love taking these patients. It's what they do. They're excellent at it. They've probably figured out ways to make transportation challenges less by partnering with, I've heard of things even like local church communities will have shifts where they'll help provide transportation. Like there's so many creative solutions that people out there, I'm sure, have figured. And so leaning into the things that are already happening, I think is a solution separate from, let's design a new solution or let's bring in something completely new. Like you can also just take what's working and amplify it.
Yeah, I think that that's really the best solution. That's where we feel like we have the most success. It's when we can identify something that is working well in a small scale, and how do we get you to do more of this, whatever that might be. Yeah, I think that that's exactly right. And also, I think that you get the buy-in from the community as well, because it's already a trusted community partner. It might already be somebody that the child welfare system trusts as well. So thinking about how you get everyone on board with what you want to do, really taking an existing resource and building that up is often your best opportunity there. Yeah.
Yep, totally agree. How do you think about, this is a very heavyweight in-person approach to solving a set of problems that children in welfare might face. How do you think about in-person versus virtual supports? As an example, a lot of the inspiration for what we're doing in the peer support realm was Big Brother, Big Sister, which is a very much boots on the ground in-person model. The challenges of that model are that the people who are coming to mentor the kids can only come once a month. They don't spend very much time. The positive is that they're actually in person with them, right? Compared to a virtual model, can be much more active, but is not actually going to be there with them. How do you think about virtual versus in person, and where are you excited by opportunities to intervene virtually?
So I can tell you what I'm really excited about, but we haven't made happen yet. So I've always thought that, especially with children in foster care who we know move frequently, and that means changing providers frequently, constantly retelling their story. I've always thought, wouldn't it be great if there could be a virtual solution for kids so that even as they move, their providers move with them. Instead of them changing providers, they continue with their providers, and they with virtual care.
And this is full PCP, full primary care?
I'm thinking about this more for behavioral health, honestly,
okay.
For behavioral health, so that there's not this constant repetition, or also being able to connect kids to evidence-based practice providers, so providers who are delivering evidence-based practices with where we can see more promising outcomes, allowing that to be able to follow the child so they're not constantly restarting. We haven't really seen that happen, and I think the child welfare system has been a little bit slower to really take hold of virtual services. So there was a time when we really saw a real resistance to any kind of telehealth services for kids in foster care. COVID has changed that. So when they had to move to a virtual environment, I think people started to realize, okay, this can work. And so what we're really seeing in most states is that people are wanting to see some virtual opportunities, but they still want to see in person as well. So there are very few things that people feel like they're really comfortable with having the kids get just a strictly virtual service. They really want to see, especially with the young kids too. I mean, because young kids don't necessarily do as well in a telehealth environment, depending on what the diagnosis might be, attention spans and things like that. So we're seeing more virtual services be made available, or obviously they've been available for a while, but the people are taking advantage of them more, and there's more of an acceptance there. I do kind of land in the camp there's probably a good mix. I think having both options, I think, is really important. So having the ability to, have the telehealth solution, especially in the rural areas where it's very difficult to get services to families, but then also having that opportunity, maybe it's less frequent, but there is that, actual direct face-to-face interaction, I think is important too. So I think it's got to be a combination. And I think we're still really trying to work to figure out exactly what is that right fit. But another area that really kind of has started to take off is some of the for physical health for virtual care to avoid ED utilization. So thinking about times when you might want to take a child to the emergency room where it's going to be a 5-hour wait, and that's not fun for anybody. There are some telehealth providers that have come online recently that we've started to use that I think have had some really good outcomes with our kids to allow a much more convenient way for families to be able to access some of those services when they need something after hours for like an ear infection or a rash or something like that. And then they avoid taking the child and potentially other children in their home to sit in the ER for, extensive periods of time.
Yeah. It makes sense. Like, hey, do I need to go to the ER? No, you can wait. It's like just the peace of mind of knowing that would be so helpful.
Exactly.
So the Center of Excellence is clearly one way that I think your team at Centene is really trying to push forward. What are some other things that you feel like
the team that you got at Centene is really doing that maybe you don't see other folks in the managed care space doing when it comes to this population?
Yeah, I think our investment in training for our providers is a key area that we've really invested in as well. And we don't see that happening necessarily across the board, at least not at the same level of a commitment that we have. One of the models that we train in really extensively is trauma-focused cognitive behavioral therapy. We actually have one started by trainers of that model on staff. And so we are consistently training in all of our markets where we're serving children in foster care, and not only providing the training for the model, but also providing the consultations that needed so that they can actually tap for national certification in that model. But not only training for our providers, we're also doing training with our caregivers and our stakeholders. So we have a team of trainers at Centene that focuses on delivering just basic education about how to manage difficult behaviors, trauma-informed care, attachment, and those kinds of things, what to expect from therapy. There are a lot of different training initiatives there that families are able to access virtually so that they can, get the skills that they need to be able to better serve the kids in their home. And so that's definitely been a big source of support, and we actually make that available across the board. So we don't do anything to check are you enrolled in one of our health plans or anything like that. If they stumble across our trainings, they're welcome to participate. It's something that we really do to just really promote the training that's needed for this community. We also
For the world too.
we partner with the National Hospital Brand Association as well for their training platform, so that they're doing some training as well, and so we partner with them to make that available more as an on-demand. The trainings we do are live, but virtual. The trainings through the National Foster Parent Association are recorded, so it really is a little bit even more so at the convenience of a foster parent to be able to participate in.
That's great. You've seen a lot of improvement. You've also seen a lot of things not improve, and some of the challenges that we talk about in this space just feel so challenging. What keeps you optimistic, and maybe what are you most excited about over the next 5, 10, 20 years that you think is coming in terms of driving better outcomes for youth in foster care and childhood welfare?
I'm really excited to see just the changes that states are making as they look at what kind of what population they should card into this specialty contract. So we're seeing some changes to where not just kids in foster care. First, they started to see some include the adoption population, understanding that whenever the adoption finalized, the issue that led your child coming into foster care is still there. Trauma is still there. All those experiences are still there. So understanding that they still also needed a specialized approach to how to manage the care for them. But now we're seeing states kind of expand to look at kids with serious emotional disturbances that aren't necessarily even involved in the child welfare system yet, or even including biological parents, giving them access to the specialty plan so that the health plan can actually work to support that parent as they're working to get the child back into their home. So that really makes me excited to think about how we can think about this more from a family perspective, because historically the way this has worked ever since we started managing care or this group is that we're focusing on the child. The child is who's enrolled with us. And so we try to do what we can to support individuals that are caring for that, but there's a limit in terms of what we can do. But I think if we can somehow tie together those parents that are trying to challenge to go back, there's a real opportunity there for us, I think, to have a real significant impact if we can think about this more from a family perspective and not just looking at a child.
Yeah. I mean, and if we're talking about preventing the kids from ending up there in the first place, like, so obviously has to include the family.
Yeah. And when you think about trying to make sure that once there's a successful reunification, keeping the child from coming back. Or the same is true with adoption. I think that the work that we do with our adopted families is very much a prevention focus, because we want to make that adoption successful. We want to preserve that family as well, and prevent that disruption. So I think both of those, it kind of you're intervening and you're trying to get to a positive outcome, and then I can get to just a prevention mode with that family to prevent them from returning to the system.
Yeah. Thank you for the work you do. Thank you for your entire career focused on this. I'm so glad that there are smart people like you focusing and trying to help these kids who really do need it most. I asked, this is my same final question to all guests. So if you could snap your fingers or wave a magic wand and you could change anything about the way our child welfare system works to drive better outcomes to help kids, what would you do?
Okay. I've got two ideas. I'm going to say the first one here, but I feel like we talked about it a little bit too, access issues and, the provider shortages that we see everywhere. We could wave the magic wand and make the providers out there all accept Medicaid and make the services available to all. I think that would be one thing. But the other thing I want to talk about that we haven't spent time on is thinking about how we can pool the fundings that's in place to serve the kids. So we look at managed care, we have a pot of money that's related to their healthcare services, the child welfare system as their pot of money. And in some states, there's behavioral health that's even carved out in a separate way. And I can invest in services for healthcare needs of the kids. And if I make it, and I've got to show my costs have to kind of level out in that bucket money, right? I've got, if I invest money here, I've have a see a return on that investment here. If that return on investment happens over here because the child spends less time in child welfare, or maybe they don't enter the juvenile justice system, there's nothing that sort of puts that together to where it's a win for everyone. And I don't know what the answer is and how you would potentially pull all of those resources together so that you could invest in one area and the outcome can happen in another area and everyone would view it as a win. But I think that that's really the ultimate thing that needs to happen when we think about how we're funding the services that kids receive and how the family DIRC are accessing services, hitting all that together so that we can actually, I think, look at what the family needs without thinking about it. It can just respond for that.
Yeah. Like education too. Like,
Education, you can have a,
if kids have better health outcomes, they'll have less truancy, they'll have better education outcomes, they'll be more likely to end up in college or trade school, which kids out there. Like it's
on and on and on,
yeah.
right?
Yeah. And it is interesting just how I don't know enough about sort of the cultural history of why the silos exist so heavy at the state. But ultimately, like the state is the one funding, supporting all of this. They are the ones attributable to the outcome. And in a way, like doling out the different responsibilities to the ed system, to managed care, to DSS. Like you sort of lose the actual incentive alignment that you naturally have with a single payer, which is kind of sad when you say it that way, because someone is accountable. It is the people at the state. That seems like a policy issue. So I'm sure for another conversation. Thank you. I'll give you back your afternoon. This is great. Really appreciate you making the time. Is there any way, if anyone listens to this and they're compelled to try to help or support the work you're doing in any way, is there any way that you want them to reach out to you or get involved?
Yeah, I mean, definitely. I think my email will be available.
You can make it available if you want.
Absolutely, yeah. I think people can reach out to me if there's anything that they would like to get more information about. I'd be happy to respond.
Cool. Thanks.